This is Ruth taping off for Chapter 10. It's positioning, moving, and ambulation. First thing we're going to talk about is body alignment. This is when we want the body in proper position in bed. We do not want their shoulders over to the left and their feet over to the right side of the bed. We want correct alignment. So when we place the resident in correct body alignment, we need to be careful that we are lifting them off of the sheet or using a turning pad, because we do not want to cause shearing. Shearing is the forces that cause the skin to move one direction and the tissue to move another. That can cause damage. So like I said, when you are lifting them up in bed, please lift them completely off the sheet so you don't damage their skin. Proper body mechanics for you is very, very important to protect your back. Your back should be straight and you should use your thigh muscles. You never twist when you're lifting because that will pull muscles. You hold your weight close to your body, and this is even in every day when you're carrying a heavy box or whatever. You always hold that weight close to your body. And then when you go to transfer a resident, you put your feet at 12 inches apart for a broad base, and that helps when transferring them. Then also you tell your coworker what you're going to do so you guys are not working against each other as you transfer. Positioning a resident in bed. This is done every 2 hours, and they may have something on their wall called a turning sheet, and usually it's like a clock. And so at noon they would be on their back. Then at 2 o'clock you would turn them on their right, and then at 4 o'clock you would turn them on their left, and that just kind of helps you keep track of what position they've been in for 2 hours. And it's very, very important to help prevent skin breakdown that we move these residents. There's something that you can use when positioning the residents. You can use a blanket or a towel and roll that up, kind of like we did with the bed sheets when we made an occupied bed. This is called a trochanter roll when you roll it like that. There's something called a footboard that you can place at the end of the bed. This is also to help prevent foot drop, to keep that foot in proper alignment. But you can also use turning sheets, draw sheets, and then you can also use the big chucks, we call them, or incontinent pads to help move the resident also in bed, as long as you're not causing that shearing force. How to position the resident. This is one of your skills. It's the 3-point positioning in bed. First you move their feet, then their hips, then their shoulders and head. And this is to obtain proper body alignment in bed. Then you want to log roll the resident like somebody that's had a hip. That's where you move them all in one motion. And please do this with 2 people, because a lot of the beds do not have side rails on them. So you need a person on each side of the bed to do this for safety. Now there's several positions that the resident can be in bed, but the 3 most important ones that I want you to know is supine. That's when they're laying flat on their back, looking up at the ceiling. Fowlers. This is when the head of the bed is up at a right angle. This is used when they're eating or using the bedpan. Now there is something called a semi-Fowler's position, and that's where the bed is part way up. The head of the bed is part way up. It's not at a total 90-degree angle. This is used this helps the resident not to side down in bed, but it's also used for people that are on oxygen and have problems breathing. They may slightly want the head of their bed tilted up in a semi-Fowler's position. Positioning in a chair. We use protective devices such as pillows. Sheepskin is that real soft material. Foam or gel pads for them to sit on or to help them position in the chair. And then we like to cover their elbows and their heels, because their heels may be on the foot pedals, on that hard metal, or they may put their elbows on the armrest of the wheelchair. So what we will do, we will cover the elbows and the heels with protectors, and these are kind of like a little cap shape that are usually sheepskin, and they have a Velcro on them, and that's what we usually use. Postural support, this is for upper body. Devices to help the resident sit up straight. You can use pillows, or there's specialized wheelchairs that come around the patient's body to help them sit up straight. Sometimes there's something behind their head on the wheelchair that helps them sit up straight. Transferring a resident from the bed to the chair. Like we talked about, make sure they have proper footwear on that's got good grip on the bottom. Like I said, they can use gripper socks, but they cannot be bare feet and use regular socks. You use your gait belt, and when you put that gait belt on them before you transfer them, be aware if there's any ostomies, like colostomies or urostomies. Remember, colostomies are for the bowel and urostomies are for the urine. Or if they have any abdominal incisions, even any hernias, you've got to be careful where you place that gait belt on them. Find out which side is their weaker side. Maybe they've had a stroke, but also each one of us has a weaker side. Like I am right-handed, so my weaker side would be my left side, because my right side is my dominant side. Make sure they can see the chair that you're going to transfer them to. This just reassures them. They know where they're going. Guidelines for transferring. Of course, you tell them what you are going to do along with your coworker. You reassure them. If they said, well, I need more than just you to help me get into that chair, then please go get somebody else, because the resident will feel a lot safer if they think there is enough help. Be aware of any tubes. This is like oxygen tubes, Foley tubes, and you may even see where they are getting antibiotic IVs in the nursing home. So you need to be aware of where all those tubes are so you don't accidentally pull them out. They could also have a feeding tube into their stomach that may be connected, so you've got to be aware where that is. And use your gait belts. Make sure your wheelchairs and your bed are locked. And protect their arms, and you know where their arms are so they don't get caught in the wheelchair or in the chair that you're moving to, or in the side rail if they have a little rail that helps them position. And then cover them, because these people, remember, their circulation has slowed down, so they chill really easily. Make sure you offer a blanket to them after you get done transferring them. Of course, you always make sure there's a call light within reach. And something when we need to talk about, when you have the resident in the wheelchair, it's easy for them to tip forward if you hit like a bump when you're going down a ramp. So you always back down the ramps, and you always back into the elevators and back into doorways. That's just so you don't accidentally throw them forward out of the chair. This is much, much safer way to do it. Ambulation is just basically walking around. That's what the word ambulation means. Safety, there again, you have proper fitting shoes. Make sure their cane or walker is in good repair. Sometimes we put tennis balls on the bottom of their walkers so they slide easier. Your gait belt, of course, anytime you're ambulating somebody, even if they're just one assist, you put that gait belt on them. The only time they don't need a gait belt is if they're independent. And don't suddenly turn to the left or to the right. That will throw their balance off. And there again, explain what you're doing, where you are going. Mr. Jones, we're going down to supper. We're going to take a left up here at the end of the hallway. Then they know where they're going. And then watch for fatigue, or if the resident gets tired, because then they'll be more prone to falls if if they're tired and lose their balance. Okay, that's the next thing that we're going to talk about is falls. Falls is a position that you find the resident in that they normally are not in. So if you find a resident on their knees, on their floor, and they say they are looking for something, and they normally don't do that, that is considered a fall. A lot of times the residents will say they're on the floor looking for something because they don't want you to know that they fell. Now, I will give you an incident where I was in a facility and I went by this gentleman's room and he was crawling around on the floor and there were pillows on the floor and there were cushions off of his couch on the floor. So I went and told the nurse that I think he fell on the floor. He's crawling on the floor. And they said, no, that was normal for him, that he liked to crawl around on the floor. And they had it charted in their care plan. So that was not considered a fall. But more times than that, not, you will find them on the floor, and that is considered a fall. Causes, there again, improper footwear, probably socks, bare feet, or their favorite shoes that have slick bottoms. Clutter, this could be magazines or newspapers that they've thrown on the floor. Rugs, and we really don't let them use the rugs in the facilities. Tubing, there again, your oxygen tubing, your Foley tubing. You need to watch where that is because sometimes they trip over that. And if you've got a resident that is independent, sometimes we will, or a resident that just needs minimal assist, what we will do, we will give them an extra long piece of tubing from the concentrator, the oxygen concentrator. And this is so that they can get into their bathrooms. Well, a lot of times that extra long tubing gets in the way and causes falls. Now, medication can also cause falls, whether they're on a new medication like for high blood pressure, whether they're on a new pain medication, then it may make them dizzy and less alert. So that is a big risk for falls. These are some of the things that we just kind of watch for to see if they're potential for falls. Now, this last slide that we have for this section on positioning, moving, and ambulation, chapter 10, it is the results of falls. They could fracture their hips, they could break like their ankle or their arm, their wrist when they fall. They can have head injury and have problems then cognitively after they've had head injury from a fall. They can also have skin tears. Now remember that we told you that their skin becomes very thin with age. So as they fall, they may have cut their arm on the bed or the bedside table and tore their skin. And then also bruising from the fall. These are the things that are result from the fall. This is the end of positioning, moving, ambulation, which is chapter 10.